then you also have to look at some biomarkers where historically patients would fall. The problem with some of the biomarkers and the blood tests are many of the blood tests could vary, even from a similar sample, from sample to sample. You could retest the same sample, you might get so many points difference in the testosterone level. And so if you've got a threshold or a cutoff, and they're just a little bit on one side or the other, and say, oh, you don't need treatment, but yet they've got all the symptoms and all the other metabolic indicators that there's something wrong, then I think that's wrong, because they may be helped, or maybe they need some coaching to see if that can bring it up. But many times when they arrive on the doorstep, if you will, they've already tried those things or think they've tried those things. And I think there's only so much you can do, because those habits will last a while. You've got to find a happy, comfortable middle ground. Because like when someone's trying to lose weight, for instance, or get into shape at the beginning of the year, they're very focused, early January, maybe February, and then starts falling off in March and the rest of the year. You've got to look at the average of what people do. And if they can't maintain that, and even maintaining that might not be good for the testosterone levels, that level of intensity of exercise and maybe going to the gym every single day, that will wear out your testosterone levels as well. So it's not always possible to raise the levels with just that. It helps, you can see the cholesterol levels going down, that sort of thing. But when all else fails, you got to have a serious discussion with yourself, with partners, and with the doctor to see if this is the right course for you. And obviously we're going to look at biomarkers, but not just the total testosterone. We're going to look at calculated free testosterone. We're going to look at, like I said, the other metabolic factors, HbA1c, the cholesterol. We'll look at it, see if they have hemochromatosis. Is that the cause of the low testosterone? We'll really dig down if there are vitamin deficiencies. Is that the cause of low testosterone? So the criteria is based on that. And then the guidance talks about, and I think in the UK, it's 15, well, in the ISS, International Society of Aging Males, I think some of the doctors will say deficiencies of testosterone, symptoms of testosterone could start as high as 15 nanomolars per liter. Okay, so 15 nanomolars per liter, I think I should go to my own conversion, I think is just about 450. Could be wrong on the US scale. 400, 450, I think is
I think that's probably right.
When the early symptoms, and to be fair, 450, 500 was a low cutoff point in the 90s for low T, and obviously that's changed. I mean, how do we get from that to 300?
And sometimes they even go as low as like 270, 280, depending on the area, like LabCorp or Quest. They have different numbers they go to. I mean, I'm sorry, but that's insanely low.
But they'll say they come up with it looking at the patient base. They might make their own determination. But who's making the determination? This is frustrating across the board, because you can look at things like biomarkers like HGH or even thyroid, but more so like the testosterone and growth hormone, IGF-1 levels, is who decides what a healthy level is, right? So I think there were studies done. I think the same guy I mentioned before, Vermeulen, we pronounce his name right. They did a study in the 90s that looked at diabetic patients, average testosterone levels, free testosterone levels across a age range, and then non-diabetic patients. And obviously, non-diabetic patients are going to have a higher level of testosterone, and they're much higher than today's norm. And they could look at the median or how it's spread across to different population groups. And again, they were higher. And now the other consideration is, how does one titrate levels? What do you titrate them towards? A younger person's, because in the realm of the anti-aging or age restoration, is you don't want to be a 50-year-old with 50-year-old levels. You want to be a 50-year-old with 25 or 30-year-old levels.
Right.
You keep dropping down. So there's no point in replacing naturally low testosterone levels with artificially low testosterone levels, because I mean, you may as well just keep your own, with the exception that perhaps and this is very important, when patients will get their blood results, especially after treatment, and especially with some of the topicals, the creams. It's really hard because you're trying to pinpoint a particular number, and people will be happy or sad by the number. We all do it. I've done it before. Right? If you get a number back and you're disappointed what it is. But we forget that we can take things out of context. So what I mean is, the testosterone cream, scrotal cream, or even the gels, you apply them, and then people would say, well, I've got lower levels than when I started because I started on the gels. because we measured them, or they got measured too late, or they went in and didn't do, I think for the gels, the guidelines are within 5 to 6 hours after application. Now, there's no rhyme or reason why. I think it's just to satisfy the patient that, okay, it's getting into your system. But what we traditionally do with injections is you want to look at the trough, the lowest level.
Right.
So, am I going to be too low before the next injection? But what can sometimes happen is those numbers might look lower than someone was anticipating or would like. But it doesn't mean it was low on the peak, because we know injections and even the creams, they spike and they fall back down. And if it's the creams, that's going to happen in a shorter window. So you have to, essentially, if you look at a graph, you have to measure what's called the area under the curve, and you have to compare the two. I think that's some form of calculus. You compare these areas to know what you have. But people don't see it that way. They just see that one number, say, I'm low, this must not be working.
Right.
So ideally, there'd be something you can put on your arm that would measure you hourly. And then you can see it would graph out on your phone, right? Or and see all the different hormones. But I don't think we're there yet. So the other way to do it is you can do to satisfy that patient. You can get a mid peak, because if you get a peak, then they'll say, "Well, you're overdosing me because my levels are too high." But then that would be the level to expect them. And sometimes I've heard this from other clinicians who will look at a level and it shows outside of the range. And they don't understand the context. Well, that test, because let's say you need to do a thyroid test and you couldn't wait until your trough level, you end up getting a peak or mid peak, and it's outside of the normal range, and they say you're on too much medication. But hang on a minute, I was only doing a fraction of what the guidance talks about doing, a full 250 milligrams of a testosterone ester every 3 weeks. Okay. Or maybe 2 weeks if, some trans men get it every 2 weeks. That's literally written on the package leaflet for some of the medications. So trans men get to take it every 2 weeks, and everyone else every 3 weeks. That's if you were to follow the package leaflet or the NHS protocol. So if you were to take that 250 milligrams and do a measurement the day after or 2 days after, you would have a massive spike. It would probably be 2,000 nanograms per day. But that's the traditional way of doing it. And then if you measured it 3 weeks later, then you'd be you'd be hypogonadal again, back to where you started.
Right.
So that's where the area under the curve makes a difference. But it's not fair to leave a man hypogonadal for 2 weeks because some of the esters will only last about a week reasonably.
Yeah, exactly.
So it makes no sense. So to have a doctor, question another doctor to say, "Oh, why is this patient's levels are too high?" Or even a patient to question you, say, "My levels are too high." It's only, you have to put it in context, and it's only based on the time in which you took it. So if you realize the time that you took it, that yes, that was my peak, then you label it as a peak. If that's my trough, it's a trough. It doesn't mean, so even if your trough comes down to where you started, it doesn't mean you were that way in the beginning of that dose. And that's something a lot of patients need to get their head around, because they'll say, my levels are this. Well, those levels are dynamic. They're not static.
Exactly.
So your level was this at this point in time. And I think a lot of people have a hard time getting their head around that.
Well, and I'm glad you brought that up, because that's a factor that I don't hear anybody talk about that. Literally, I've never heard anybody bring that up or talk about that. And that's such a good and valid point.